Hello everyone, welcome to Patho Excellence. In this endometrial pathology series, in episode 12, we are going to discuss the assessment of invasion. Understanding invasion is fundamental not only for accurate FIGO staging, but also for determining prognosis and guiding treatment decisions. So today, we are going to discuss different types of invasion. Key points are how to accurately assess the depth of myometrial invasion, distinguishing true invasion from mimickers such as adenomyosis, cervical involvement, and lymphovascular space invasion. So, why do we measure myometrial invasion? As we have discussed, because the depth of invasion is one of the most important factors in FIGO staging. So, it is helpful for prognosis and management. Now, how to measure myometrial invasion? So, for the myometrial invasion, we require hysterectomy specimen. It is not possible on biopsy specimen. So, for the depth of invasion, endomyo junction to deepest point of tumor infiltration, which is measured, and it should be done on full thickness section that includes entire endometrium, adjacent myometrium, serosa, and importantly, deepest point of tumor invasion. So, suppose if endomyometrial thickness is more than 3 cm, the tissue may not fit in one cassette, so we require bisected slender sections, or we have to submit in 2 consecutive cassettes so that we can exactly measure the myometrial invasion. Now, why it is not as simple as it sounds? So, several challenges complicate this accurate measurement. One is irregular endometrial-myometrial junction. So, the boundary is often undulating and it is difficult to find a consistent starting point. Second thing is presence of adenomyosis. So, suppose cancer can appear deep simply because it is invading pre-existing benign glands and may stimulate deep invasion, or we have to distinguish direct invasion from colonization of adenomyosis. And third point is different invasive patterns like MALF pattern. MALF means microcystic elongated and fragmented pattern. We will discuss in detail in later on this session. And diffuse infiltrative pattern. So, it makes it difficult to identify the deepest tumor point. Now, endomyo junction is a boundary between the endometrium and myometrium. So, why it is hard to identify? Because it is normally irregular. Tumor can distort the interface and there is reactive stromal change which can mimic invasion. So, for the detection of endomyo junction, we require scanner view. So, see here in this section, this is a normal endometrial endomyo junction where you can see there is irregularly placed endometrial gland and this is myometrium. So, this is the irregular junction which may make difficulties in identifying myometrial invasion. So, use low power and normal EMG shows smoothish, undulating but continuous border. And what are the features that suggest true myometrial invasion? First is loss of normal endometrial stromal cells. So, cancer directly touches the myometrium without any stromal buffer. Second thing, normally basalis glands are present at the junction of endometrium and myometrium. So, if there is absence of this interface, it favors invasion. Third is presence of thick-walled blood vessels. So, these blood vessels are helpful because normally these vessels are present in the outer half of the myometrium. So inner half of myometrium is devoid of thick-walled blood vessels. So if tumors are adjacent to these thick-walled blood vessels, then it is suggestive of deep invasion. So this is myometrial invasion, where we can see this is the tumor part and it is directly touching to myometrium, and there is no what is called gland, which is basalis layer, which is absent here. So this is myometrial invasion, and there is no stroma surrounding the malignant glands. Here we can see this is the growth and these are the blood vessels, thick-walled blood vessels, which is present normally in the outer half of the myometrium. So here this is called deep myometrial invasion because tumor is nearer to this thick-walled blood vessels. Here this blood vessel shows monkey-burst calcification in the vessel wall. So this is medial wall calcinosis and indicative of invasion. So these are the conditions where you can say myometrial invasion present or absent. So benign glands at interface of tumor and myometrium if present, no invasion. Fibrous or myode metaplasia of endometrial stroma if it is present, there is no invasion. Loss of endometrial stroma as well as desmoblastic stroma if present, it is called true myometrial invasion. So here in this section we can see adenomyosis, here the gland is present and this stroma is showing smooth muscle bundle, and this is the metaplastic stroma which is CD10 positive. So smooth muscle metaplasia is present, and this is the metaplastic change of this stroma, and this is the adenomyomatic gland. So this is not an invasion. Now, important pitfalls. So do not confuse exophytic growth with invasion depth. So an outward projecting polypoidal mass may appear thick, but true invasion is based on the penetration of this tumor into myometrium. So it is not actually the tumor height. Now stromal metaplasia may mimic invasion. Endometrial stromal cell may show fibroblastic metaplasia, smooth muscle metaplasia that is resembling false myometrial appearance. And sometimes CD10 helps because endometrial stroma, even metaplastic, they are CD10 positive. If CD10 negative and myometrium is there, so it is useful in difficult cases. So to avoid overcalling deep invasion, we have to look at low magnification, look for loss of basalis glands, identify thick-walled vessels. Whenever confusion, we can use CD10 and never measure exophytic tumor thickness as invasion. Now, adenomyosis. Most of the uterus we saw adenomyosis. Whenever there is adenomyosis presence is there, they are generally benign endometrial glands surrounded by stroma, endometrial type, and located within the myometrium. So this becomes difficult when the stroma is sparse and when it shows metaplasia. So whenever we see adenomyomatic glands, we have to see the surrounding stroma present or not. Now, what are the diagnostic challenges? If endometrial carcinoma arises within adenomyosis or it invades into adenomyosis. So this makes it difficult to distinguish from true myometrial invasion, especially on frozen section. So what are the situations that cause confusion? So astromal adenomyosis. Sometimes stroma is very scant and cancer appears adjacent to myometrium, so it gives false diagnosis of invasion. Second thing, Smooth muscle metaplasia, as we have seen in earlier slide, there is CD10 positive stromal cell which can look like smooth muscle cell and it can mimic myometrial invasion. And whenever there is fibroblastic or muscular metaplasia, there is no invasion. So, as we have discussed, adenomyosis, for that we have to see preserved stromal cell. But if cancer is arising in adenomyosis, so tumor grows outward from the adenomyosis next, right? And measurement of depth of invasion require outer border of adenomyosis and not from the endometrial myometrial junction. So we see later on. Now CD10 pitfall, sometimes CD10 highlights endometrial stromal cells, but smooth muscle around invasive carcinoma may also be CD10 positive. So sometimes it is not helpful as much for invasion criteria. So this is important, the diagram to measure how to measure myometrial invasion. So in this first diagram, if endomyojunction is regular, then the junction to the tumor part, that is we have to measure, and this is called actual measurement of myometrial invasion. So this is called depth of myometrial invasion. Suppose endometrial and myometrial junction is irregular, then we have to see the deepest point of the junction to the tumor for this DMI. And in case of exophytic growth, see this is tumor portion, this is myometrium. So this is the junction of the endometrial and myometrial junction, and here this is the exophytic growth. In this diagram C and D, we can see exophytic growth. So the actual junction is this. We have to draw the line from this endomyojunction to the deepest point of this tumor part. So here this is actually the depth of myometrial invasion. Here also there is what is called exophytic growth. Here the deep portion of invasion is here, but still there is foci of tumor here also. So the deepest portion of this tumor foci to endomyojunction is called depth of myometrial invasion. Now in case of adenomyosis, if adenomyosis is showing a tumor itself, then the junction between this adenomyosis and the tumor foci we have to measure, and it is called depth of myometrial invasion. So this is the important criteria for a myometrial invasion measurement. Now see here we can see this is a normal stroma surrounding the adenomyomatic glands, and this is normal endometrial gland. They are adjacent to the cancerous gland. So this is endometrial carcinoma arising in the endometrial adenomyotic foci. So this is this is smooth muscle, adenomyomatic glands, and tumor arising from this adenomyomatic gland. Now there are few patterns of myometrial invasion. So one is conventional invasive pattern, which is irregular infiltrative glands. They are angulated haphazard glands, and surrounding this tumor there is desmoplastic stromal reaction. So fibrous component is there. This is classic feature of myometrial invasion. So this is muscle malignant glands, and this is desmoplastic stroma. Second is bulky pushing type of invasion, where there is broad, smooth pushing border and generally no desmoplasia. So here diagnosis is based on absence of endometrial stroma, no benign or basalis at interface, and association with thick walled vessels. Now newer pattern, recently recognized spatial patterns are, one is MALF pattern, which is microcystic, elongated and fragmented. So here glands become microcystic, elongated, infiltrative and fragmented, associated with myxoid stroma and minimal inflammation. So they are easily mistaken for benign glands or degenerative changes. Second pattern is adenoma malignum-like pattern. So they are deeply infiltrative glands. They are dilated and they are deceptively bland mucinous gland. So resembles minimal deviation adenocarcinoma and they lack desmoplasia. So this is tricky to identify an invasion. So MALF invasive features as most associated with grade 1 endometrial carcinoma, and as we have discussed, they are microcystic or resembling like lymphatics. Tumor cells commonly have eosinophilic cytoplasm. Acute inflammation is generally present in the lumen and inflammatory and myxoid stroma is present. So in this type of pattern, there is decreased expression of hormone receptors and E-cadherin, and they are positive for cyclin D1. So this pattern is seen in 7 to 45% of endometrial cancers, and they are having increased incidence of true lymphovascular invasion as well as nodal metastasis. So this is MALF pattern. By looking at low power, we can say it mimics like a lymphovascular invasion. But if we see in high power view, it is the attenuated cancerous gland, focally broken and bland looking, and small cancerous gland within this large glandular space is present which simulate lymphovascular space. So this is MALF pattern. Here also these invasive glands are having microcystic pattern here we can say, and this is having cleft-like pattern. So and surrounding there is acute inflammation. Here in this section, this is a uterine serosa and this is MALF pattern. Here again MALF pattern where we can see these are the small cystic glands, and some of these cells are singly present and contains large amount of cytoplasm. It simulates macrophages, and here we can see extensive inflammation. So this is MALF invasive pattern. This is again a microcystic gland, incomplete glandular structure, and which is surrounded by this fibromyxoid and inflammatory stroma. Now adenoma malignum-like infiltration. So it is diffusely infiltrative endometrial adenocarcinoma, and in which we can find scattered round regular glands situated in myometrium, no jagged contours and no desmoplastic stroma, and which mimics stroma poor adenomyosis, and tumor glands mostly arranged haphazardly. So in this all four sections, low power view, we can see this is the myometrium, which is infiltrated by these small regular cystic glands, and some of the glands show angular wall. So this is adenoma malignum like infiltration. Here This is gland without any stroma but have invaded the myometrium. And no desmoplasia, only the gland in the myometrium. So this is a diffusely infiltrative adenoma malignum-like invasion. Now, cervical involvement. So there are two types of involvement, endocervical mucosal involvement and cervical stromal invasion. So endocervical mucosal involvement, it is not considered in a FIGO staging, but the cervical stromal invasion, it must be identified accurately because it indicates stage 2 disease. Now what is the diagnostic challenge? So because criteria are not well defined and particularly difficult when tumor is located at mucosa stromal junction and low power architectural assessment is required. So what are the clues against stromal invasion, cervical stromal invasion? So tumor shows similar distribution to benign endocervical glands. These benign endocervical glands are seen beneath the tumor. No infiltration beyond the normal glandular zone. So this is not stromal invasion, only mucosal involvement is there. Now for the true cervical stromal invasion, tumor is located deeper than normal endocervical glands. Cancers extend beyond the expected endocervical gland distribution, and invasion can be diagnosed even without desmoplastic reaction, and it is true cervical invasion and it suggests FIGO stage 2. So here in this both the diagram or both the section we can see this is the squamous epithelium of cervix and this is the stroma where we can see these are the malignant glands invaded the cervix. So this is true invasion, cervical stromal invasion. Here, this is the part of cervix where this tumor is located here and beneath this tumor there is benign endocervical glands. So this is without stromal invasion. This is direct spread to the epithelium of the cervix. So this is true stromal invasion here. It is indicative of malignancy without stromal invasion. Now, lymphovascular space invasion. Definition: presence of tumor cells within lymphatic or blood vessels. It is common in high-grade endometrial carcinoma, rare in low-grade endometrioid carcinoma. It is not part of FIGO staging but an independent adverse prognostic factor in early stage disease, and it helps in adjuvant therapy decision. So what are the histologic features for true LVSI? So first is tumor fitting the vascular space. So tumor plugs conform to the vessel wall. Endothelial lining may or may not be visible on HE. Conformation or adherence to vessel wall. So tumor nest curves along or stick to the vessel wall, or proximity to large vessel, especially thick-walled arteries or veins. So here this is the viloglandular endometrioid carcinoma and this is the vascular invasion where the vessels contain tumor cells. And here also a tumor showing a lymphovascular invasion. These are the tumor cells in the lymphovascular space. Here we can see this tumor nest has taken the shape of this lymphovascular space. So this is lymphovascular invasion. Now what are the mimics and pitfalls or pseudo invasion which can be misinterpreted due to either surgical artifacts, especially laparoscopic hysterectomy where floaters like free-floating tumor fragments may be present in large vascular spaces. and it do not conform to the vessel wall. So they are not adherent, but they are just floaters. Grossing artifacts, knife-induced tumor displacement into vascular space. Third is retraction artifact, where clear space around invasive nest mimic vessel lumen. So no vessel wall, no association with veins. So this is retraction artifact. Third is Melf pattern, where glands with micromyxoid stroma. But this is not true lymphovascular invasion. And fifth is histiocytoid lymphovascular invasion, where there is decisive cells with eosinophilic cytoplasm mimicking inflammatory cells, and that can be overlooked if not carefully evaluated, and we have to look for nuclear ATPR to avoid underdiagnosis. So whenever there is abundant eosinophilic cytoplasm and atypical nuclear or malignant nuclear feature, we have to think of lymphovascular invasion. D240, which is lymphatic marker, which may be sometimes helpful in case of whenever there is dilemma, but negative D240 does not exclude invasion. So routinely it is having limited value. Now, what are the other situations where we have to assess for this invasion? Like peritoneal washing. This is not a part of FIGO staging, but it indicates poor prognosis. So whenever we find positive cytology, it suggests non-endometrial or high-grade endometrial carcinoma. Second is transtubal spread. Pre-tumor cells in fallopian tube lumen seen in 20% of cases. So this is a fallopian tube. In this lumen, sometimes floating tumor cells are visible. So this is transtubal spread. This is a high power view. These are the malignant tumor cells. So recommendation is that entire submission of both fallopian tube is required. Second is parametrial invasion. It indicates poor prognosis and assessed only in radical hysterectomy when cervical stromal invasion is present. And margin assessment. So total hysterectomy specimen contains paracervical soft tissue, which is only true margin, and radical hysterectomy contains vaginal and parametrial margins. And margin reporting is optional, but it indicates poor prognostic factors. So generally we used to report whenever we find this margin involved in the specimen. So this is about myometrial, cervical and lymphovascular invasion, and what are the measuring criteria. So FIGO staging require accurate assessment of all these invasion assessment. And if you like this topic, then please like, share and subscribe this channel for more such topics in depth. And next topic we are going to discuss what are the criteria for the diagnosis of well-differentiated endometrial carcinoma on biopsy specimen, because it is easy to detect malignancy in hysterectomy specimen, but for the biopsy we require different criteria. So thank you and stay tuned.